Hello. So today we're going to talk about pulmonary blood flow. The important concepts that you need to get here is that flow, or Q, is equal to the pressure gradient, shown as delta P, divided by resistance. Okay. So this equation can also be written as cardiac output, which is flow, is equal to mean arterial pressure, which is basically a pressure gradient over resistance. And the pulmonary circulation takes the entire cardiac output of the body. Okay, so that's important to note, that it takes that whole entire cardiac output. And the pulmonary circulation, the pulmonary system, is very low pressure, very, very low resistance. And the way that it regulates that blood flow is primarily through resistance. So the pulmonary circulation pressure is much, much lower than that of the systemic circulation pressure. For example, the systemic versus diastolic is 25/8 for the pulmonary and 120/80 for the systemic circulation. Mean arterial pressure is much lower, 15 versus 100. So the capillary pressures are very, very low for the pulmonary circulation. There's about 8 to 12, while the systemic circulation, the capillary pressures are about 10 to 30. Okay. Why is this pressure low in the pulmonary system? Well, the right heart, only has to pump blood to the lungs. So the lungs are basically in this area here. So you don't have to pump to the edges of the body and to your feet. You just have to pump into an area that's close to the heart. Okay, and because that pressure is low, we're going to have thin wall arteries, and also that pressure will reduce edema. Okay, so there's a safety factor in the capillaries where you basically don't want to go greater than 25 millimeters of mercury in the lungs, in those capillaries. Otherwise, you're going to get edema. So having this low capillary pressure, also reduces the probability of getting edema. So how does this pulmonary circulation regulate the blood flow? And it does it primarily through resistance up here. So, and that relates to this equation here. So you decrease the radius here. You can see that arteriole getting narrower. You're going to increase the resistance, okay, and you're going to reduce that blood flow. If you increase the radius, you're going to decrease that resistance, and you're going to increase blood flow. And if you recall that resistance is basically proportional to 1/r⁴. Okay, resistance is proportional to 1/radius to the 4th power. So there's two types of capillaries within the lungs. We have the alveolar and we have the extraalveolar. So let's look at the alveolar blood vessels. Okay, so those alveolar blood vessels surround the alveoli, and of course they dependent on the air pressure within the alveoli. Okay, so in this diagram we have the alveolus shown here with air coming into the alveolus, and the pressure in the alveoli presses on the walls of that alveoli, and it's called PA, P big A. Okay, and the alveolar blood vessels share a basement membrane with that alveoli, and that alveolar blood vessel can feel that blood pressure directly. So if that alveolar pressure increases, so the P big A increases, it can crush and close those alveolar blood vessels. BV is blood vessels. If the alveolar pressure decreases, then the alveolar blood vessels will open up. Okay, now let's talk about the extraalveolar blood vessels. So the extraalveolar blood vessels relies on the pressure in the intrapleural space. So that intrapleural space is between the parietal pleura, which is attached to the chest wall, and the visceral pleura, which is stuck to the lungs. So the intrapleural pressure has two opposing forces. Okay, and what we have in this bottom diagram is we have an expansion of the thorax and chest wall and diaphragm, creating an outward pressure, and then we have a recoil of the lungs, creating that inward pressure, and this pleural pressure. And that creates that pleural pressure, okay? So the opposing forces pull on each other and create a slight vacuum in that pleural space, okay, around -5. So based on this, the one way that you can change the blood vessel resistance is through lung volume. So we have two types of capillaries. We have the alveolar and the extra-alveolar capillaries. The alveolar blood vessels, their resistance depends on air pressure in the alveoli, as shown in this diagram. Meanwhile, the extra-alveolar blood vessels, they depend on the intrapleural pressure, okay, which is basically the pressure in between the lungs and the chest wall, and you have opposing forces where the thorax pulls out and the lungs pull in, and you have basically a negative pressure in that pleural pressure. So the change in that pleural pressure changes the resistance in the extra-alveolar blood vessels. Okay, now let's look at these changes in the alveolar and extra-alveolar blood vessels with changes in lung volume. So in the first part, we're going to have increased lung volume, such as during an end maximum inspiration, so the end of a deep breath. And with the alveolar blood vessels, the alveoli, okay, expand, and that increases the alveolar pressure, which presses on those alveolar blood vessels, decreasing the radius, increasing the resistance, and decreasing the blood flow. On the other hand, the extra-alveolar blood vessels, which are outside of the alveoli, and they're affected by the intrapleural pressure, the interpleural pressure becomes more negative, okay, larger, and the lung tissues expand and pull open those extra-alveolar blood vessels. It increases the radius, decreases the resistance, and increases the blood flow. Now let's look at the other extreme, where we have decreased lung volume at the end of maximum expiration. So the alveoli are smaller, okay, and the alveolar pressure will be decreased, the P big A. That radius of the alveolar blood vessels will increase, okay. The alveoli are not pressing on those blood vessels. The resistance decreases, and we have an increase in blood flow. For the extra-alveolar blood vessels, the pleural pressures become less negative. The lungs are more compressed, okay? So what's going to happen there is those extra-alveolar blood vessels, their radius is going to be decreased. The resistance will increase, and you'll get a decrease in blood flow. So this is the effect of lung volume on the alveolar and extra-alveolar blood vessels at high lung volumes and at low lung volumes. So let's look at that graphically. So we have the extra-alveolar blood vessels, and then we have the alveolar blood vessels. So what happens with the alveolar blood vessels, as the alveoli expand, so the alveoli get bigger, expand, the resistance increases because they crush those alveolar blood vessels. Okay, so the resistance is higher. With the extra-alveolar blood vessels, as the lung expands, the resistance gets smaller because those extra-alveolar blood vessels gets pulled open by the expanding lung. Okay, so with the extra-alveolar blood vessels, the resistance decreases with increased lung volume because those blood vessels get pulled open. Extra-alveolar blood vessels get pulled open with the expanding lung. The alveolar blood vessels, the resistance increases with lung volume because the alveolar pressure kind of crushes those blood vessels. So let's sum these two resistances from the extra-alveolar and the alveolar blood vessels together. When we sum them together, what we find is that we have a curve shaped like this, where the resistance is high at extreme lung volumes, with the lowest part at the FRC, okay, the functional residual capacity. What I can point out is that that tidal volume falls within approximately that orange square, and basically you have resistances being lowest, blood vessel resistance being lowest around that tidal volumes, and the blood vessel resistance, pulmonary vascular resistance, is highest at extreme of lung volumes. So on this graph we have resistance on the Y, cardiac output on the X. And what we can see that as cardiac output increases, the resistance decreases. And this is kind of remarkable. And it happens because of the capillaries in the lungs. So the first thing that happens is recruitment, and the second thing that happens is distension. So with the recruitment, some of the capillary networks, you don't have any blood flow in the lungs, and they're recruited when you have an increased blood flow. And that keeps pressures low with a great increase in cardiac output. With distension, you have further increases in cardiac output. Those thinned wall capillaries distend, okay? They become fatter and they handle more blood. So this is how the pulmonary circulation can handle things such as exercise, where you have the cardiac output goes from 5 liters per minute to 30 liters per minute. And by having this recruitment and distension, it keeps the pressures low. Okay, so that's the importance of this recruitment and distension. Okay, so there's another way to control pulmonary blood flow, and that's by vasoconstriction of those smooth muscle of the pulmonary arterioles. Okay, so normally those arterioles are almost at maximum dilation. Okay, and the partial pressures in the lungs, the PO2, are normally, okay, about 100 millimeters of mercury. If you decrease the partial pressures of oxygen, you get hypoxic vasoconstriction. And what that does is forces blood to the healthy alveoli, and the blood is oxygenated more efficiently. So this occurs locally. Okay, so that's local changes in blood flow. You can have hypoxic vasoconstriction on a global scale. For example, when you are at high altitudes, if the baby's not breathing, or if you have lung disease where you don't get enough oxygen into the alveoli, such as emphysema. So if you decrease partial pressure of oxygen, PO2, to the entire lung, you're going to have widespread vasoconstriction of all of the pulmonary arterioles in the lung. And that increased pulmonary vascular resistance, PVR, is going to make it harder for the right ventricle to pump out blood against that increased pressure. Okay, chronically, then you can have chronic pulmonary hypertension. So you can regulate blood flow by the capillaries with recruitment or distension, or it can be regulated by hypoxia, where hypoxia results in vasoconstriction of the pulmonary arterioles. And this is kind of bad if you have global hypoxic vasoconstriction, and chronically it can lead to pulmonary hypertension. Okay, let's talk about lung zoning. Sometimes students have difficulty with lung zoning, and what it's important to understand is that there are two different factors. Okay, we have the alveoli, and then we have the alveolar capillaries. Okay, so the alveoli, we have the air pressure within the alveoli, okay, the PA. So that's the first thing that we have to understand. Then the second, we have the alveolar capillaries. So this is the alveolar capillaries, right, where the arteriolar pressure drives blood through the capillaries to the venous pressure. And that arteriolar pressure is always greater than the venous pressure, okay? And that's the driving force of blood through the capillary. So the alveolar pressures are relatively constant throughout the lungs. However, the alveolar capillary pressures change in the regards to the position where they are found in the lung, and they're affected by gravity. So in lung zoning, we have the alveoli, and then we also have the alveolar capillaries, and we have an interplay between those two. Okay, so the question is, how the heck does gravity affect the pressure? Well, let's look at this column. Okay, so this is a column of blood, and it's a certain height, and we've got some pressure in it, okay? So the equation that relates here is that the pressure is related to the density by the gravity of acceleration by the height. Okay, so you don't have to know that equation, but that basically shows how gravity affects the pressure. So basically the blood in that upright column has different pressures at different heights, and that's just due to the weight of the blood. So the take-home story is that the weight of the blood in different parts of the lungs will cause the blood pressure in different parts of the lungs to be different. Okay, now that we've clarified the alveolar pressure and the pressure gradient in the capillaries, let's look at how this affects zoning in the different parts of the lung. So in the apex, we have low blood pressure, and at the base of the lung, we have greater blood pressure. So the pressure follows that arrow downwards. So it increases, arteriolar pressure increases as you go down towards the base of the lung. And we can split the lung into different zones, 1, 2, and 3. Okay, there is a fourth zone, but we won't cover it too much. Keep in mind that the alveolar pressure is relatively constant throughout the lung, but the pressure gradient between the alveolar capillaries changes throughout the lung. Then what we're going to be looking at is we're going to be looking at the pressures in the arteriolar and venule in relation to the alveolar pressures. Okay, so let's start off with zone 3. The arteriolar pressure is greatest, okay, then followed by the venous pressure. Okay, so basically in zone 3, the blood flow through the capillaries is driven by the arteriolar and venous pressure, and the alveolar pressure doesn't play a big role. Okay, so let's look at zone 2. So in zone 2, the blood vessels, the capillaries, are directly on the basement of those alveoli, and it feels that alveolar pressure. So as alveolar pressure increases, those vessels are slightly crushed, okay, like a clothespin pinching the straw, okay? So the arteriolar pressure is still greater than the alveolar pressure, okay? So, but that alveolar pressure is the one that will determine flow through those capillaries. That arteriolar pressure is still enough to force through that alveolar pressure, okay? So you still get blood flow in zone 2. Like a clothespin pinching a straw, if you blow hard enough, you'll still get air flowing through. Okay, and now let's look at zone 1, which occurs in the extreme upper part of the lung. And that's where the alveolar pressure is greater than the arterial pressure and is greater than the venous pressure, okay? So basically those vessels will be crushed. Now, normally the vessel structures resist compression. So zone 1 tends to be a non-physiological conditions, okay? Really important. Zone 1 tends to occur under non-physiological conditions, such as if the arterial pressure rapidly decreases with the hemorrhage, or if the alveolar pressure rapidly increases, such as positive pressure ventilation. Okay. So in summary, we have the lung zoning depends on the alveolar pressure and the pressure gradient in the capillaries, okay? What we have in the lungs is that the pressure increases as you go towards the base of the lung. So the base of the lung has greater pressure and the apex has less. And that means that the arterial pressure will vary up and down through the lungs. However, the alveolar pressure remains relatively constant. So when you look at these different pressures, the pressure gradient and the alveolar pressure in relation to each other, you get these different zones. Okay, let's look at the clinical correlations with pulmonary blood flow. And the main thing that we're looking at is pulmonary edema. And we've looked at the Starling's equation, where you can calculate filtration or reabsorption. But this is a bit different because we also have to consider the alveoli. So in the capillary, we have hydrostatic pressure and oncotic pressure, okay, as typical of what we've seen before. And typically in the lung, the hydrostatic pressure is less than 25 millimeters of mercury. And that's because you want to have that pressure lower than the oncotic pressure, which is approximately 25 millimeters of mercury. Okay, so you want to have the hydrostatic pressure lower than the oncotic pressure so you don't get too much fluid being filtered out into the lungs. Now let's look at the alveoli. Okay, so the alveoli, we have surface tension that would draw water into the alveolar and interstitial space. Okay, so if surface tension increases, you're going to draw water in. With air pressure, what you're doing, and we've talked about it in the previous lectures, is that as that alveolar, you breathe in or force more air in to the alveoli, that alveolar pressure will increase. Okay, and as you increase that air pressure, you're going to crush those capillary vessels. As you crush those vessels, you're going to change the resistance of those capillaries. You're going to increase the hydrostatic pressure effectively. So you're going to have an effective increase in hydrostatic pressure as you increase that air pressure because you're crushing those capillaries. And then we have the lymphatics, which takes any fluid that's filtered out into the interstitial space. When we have edema for any of these conditions, first is we're going to have increased in fluid into the interstitial space. Okay, and that's going to make the lung soggy and difficult to inflate. It's going to be difficult to inflate. If that edema continues, then you're going to get fluid into the alveoli. And you're going to basically affect gas exchange. Okay, so with edema, you're first going to get an increase in fluid in the interstitial space. You know, the lungs are going to become soggy, a little bit heavy, difficult to inflate. And as this edema continues, then you're going to get fluid coming into the alveoli, and it's going to affect gas exchange. Okay, so let's look at some examples that can cause edema. So COPD, chronic obstructive pulmonary disease. Basically, you don't get enough oxygen into the alveoli and you have hypoxic vasoconstriction. You increase the hydrostatic pressures and you have edema. Acute respiratory distress syndrome, ARDS. You have a decreased amount of surfactants, typically in premature infants. You're going to have an increase in surface tension. That increase in surface tension is going to pull fluid into the lungs. Okay. You can have overperfusion of saline, and you're going to basically decrease the colloid pressure. You're going to basically dilute or decrease the albumin concentration in the blood. Mechanical ventilation, you're going to increase the resistance of the alveolar vessels. You're going to basically increase the pulmonary vascular resistance. And then the last one is noxious substances, toxins, etc., that affect the capillary permeability. We hadn't mentioned the capillary in the Starling's equation here, but we discussed it in the previous lecture on microcirculation. So noxious substances can alter that capillary permeability.